I think that for us as orthopedic surgeons working in the United States, it's, I think, been more challenging. And, patients present delayed. It's not their fault. They can't get into clinic. Insurance companies are a huge problem. And, they're sort of dictating what we can do, which is also somewhat infuriating. OR access for the surgeons is limited, and OR staffing is a challenge. And this is something that's completely different than 5 years ago. Like we can't hold on to nurses and, techs. And so just taking care of these people has become a lot more difficult. And really an acute distal radius fracture, as like Mark Recant was talking about, an acute scaphoid fracture is a gift. Like we just don't see these cases, within a week of their injury. It's like 2 or 3 weeks later, and then you have to figure out how to get them taken care of. And so because of all of these challenges, I think that therapy intervention really is so important. It's more important now than ever, and it really maximizes outcomes, in my opinion. And early treatment, I think, leads to quicker, better outcomes. And, a lot of times people just need encouragement. They're hesitant. They have no idea what happened to their wrist, right? Like they have no idea what you did. They have no idea what their injury is. You can talk until you're blue in the face, and they don't really get it. And they are hesitant, and they don't want to hurt themselves further. So first visit, I like to discuss expectations. I like to show them x-rays. And for distal radius fractures, the most important thing is to move the fingers. And this has been published, and this is not my idea, but I've found that that is really true. And you just have to get them moving their fingers as soon as possible. The minute they hit the door in my clinic, I take off all the splints and casts and whatever was placed wherever they were seen initially. And I start with management of swelling, and I get him over to OT for a removable splint. The OT is now, I worked on this for, probably 5 years, is available to my patients on the day of their clinic visit. And so to have a walk-in capability is very challenging for a therapist, because you may have 20 patients or you may have 0 patients. And so we were able to figure that out with a lot of discussion. And I think that has been a total game changer, because you can now see a patient with an acute fracture and send them directly to occupational therapy and have them build a custom molded splint, right? You have some arms that are skinny and you have some arms that are not very skinny. And so an item off the shelf doesn't fit everybody. So, and the patients love it. They love custom orthoses. And really the rehab starts on that day. So the therapists, they're so fabulous. They make us surgeons look really good. They start the discussion of what to do after your surgery. And really after the surgery, they're seen within 72 hours. So they're seen on the day of clinic by the therapist. They get their foot in the door, and then they know the surgery date, and within 72 hours, they get seen. So on the day of surgery, what's my goal is solid fixation for immediate motion. Again, that's sort of been the theme this morning. You can't sort of, put a couple K-wires in the distal radius that was shown earlier and hope, by Dr. Zumsteg, and hope for the best, because those just totally fall apart and those people can't start moving. So you need solid fixation, good carpentry, as Dr. Recant said, and immobilization, in my opinion, is the enemy. That's true for the elbow. That's true for the wrist. And once upon a time, we're like, cast everything for like 100 years. And that's actually really bad for the joint. So from my patients that completely ignored what I said, took off their splints, cut their cast off in their garage, they come in and they have this healed fracture and amazing motion, right? And so from these derelict patients, I actually learned a lot about how I should probably not be immobilizing patients so much. I like monochrome closure. People get freaked out when they have stitches sticking out of their skin, so I don't use non-absorbables anymore. Everything I use, unless it's an open fracture or some other soft tissue problem, I basically use absorbable sutures most of the time. My dressings are minimal. I don't wrap anything anymore. Ace bandages are the devil. You put them on too tight, their fingers turn into sausages. They like get all these funny looking skin problems. They're the devil. Like if I see a ace bandage in the room, I start to break into a cold sweat. So I don't use ace bandages. I basically use a gauze and a Tegaderm, and they do fine, because I mean, ultimately you should get hemostasis at the end of your case. So you shouldn't be bleeding out all over the place. So a very minimal dressing facilitates motion, and I don't cast and I don't splint, and I just use these volar orthoses that I really love. So this is therapists. We have therapists in the room. You guys are way more in tune with all this than I am. But this, what you guys call the early protective phase, I like this because you start therapy, but you're still protecting the fracture. And that's really nice terminology to use with the patients because it reinforces the fact that you're not going to cause harm and you're not going to displace the fracture and things aren't going to move around, right? We're going to rehabilitate you in this sort of protective environment. Start finger range of motion, take off your splint. Like if you're sitting there having your dinner, like take your splint off and move your fingers. Within a week or two, I start wrist and forearm range of motion. And then within 4 weeks, I allow them to start really pushing on it to get their motion. You want to control swelling. If you can prevent stiffness, then your pain is less and your rehabilitation is easier. It's just like the elbow. If the elbow turns to stone because you've splinted them for 2 or 3 weeks, it's really hard to move them. And so the quicker you move them, the better. So range of motion is so key. Give them things to do like putty. You can get one of these little squeezy balls right here in the lobby. You know, give them all kinds of things to do that will encourage them to move their fingers. Putty, squeezy balls. I like isometrics where you sort of engage the forearm muscles. I mean, they're not doing push-ups, right? But they're doing something to engage that muscle so that they don't get atrophy. And you have to remember the adjacent joints, the shoulder and the elbow. I can't tell you how many times, you know, I sort of focus on the distal radius, I forget about everything else, and then they get frozen shoulder. And so it's really important to really engage all the joints surrounding your distal radius fracture injury. So weight bearing is gradual. I like wall push-ups. It encourages wrist extension. It encourages forearm rotation. And that starts, you know, at 6 to 12 weeks, depending on the patient. And then you ramp it up within comfort. And then at 3 months, they have no restrictions. If all else fails, the therapists have all these brilliant contraptions that they build for these patients to work on forearm range of motion, finger range of motion. You know, they put glue on their fingernails and put little hooks on there and then pull the fingers down. Like I've seen all kinds of cool stuff. And, you know, this again, it's a lot of attention to detail to the patients, which we really appreciate. And, you know, most of the time these people do well, but like the death of a distal radius, the most beautiful operation and their fingers are stone, that is going to be a tough case, no matter how good your x-ray looks. So therapy is, in my opinion, absolutely key for these injuries.